A very good day. This session will discuss about anticholinesterases. Now, anticholinesterases are the drugs which inhibit acetylcholinesterase enzyme. And by inhibiting acetylcholinesterase enzyme, it causes accumulation of acetylcholine in the vicinity of cholinergic nerve terminals, and thus they are potentially capable of producing the effects, which is due to stimulation of cholinergic receptors throughout the central as well as peripheral nervous systems. Now, as cholinergic neurons are widely distributed across many species, and that's why it's not a surprise that these drugs are currently used as toxic agents in the form of agricultural insecticides, pesticides, and also they have a potential of use in chemical warfare as nerve gases. First, let's begin with the classification of anticholinesterases. Anticholinesterases are classified into two groups. One is non-competitive blockers, and the second group is competitive blockers. In non-competitive blockers, they are also called as irreversible inhibitors, includes organophosphorus compounds, for example, diflos, icothiopate, parathion, malathion, diazinon, tabun, serine, soman, which are nerve gas agents. An example of carbamates is propoxur. So all these drugs are non-competitive blockers, are irreversible inhibitors. The next group is competitive blocker. Now, competitive blocker includes drugs like physostigmine, drugs used in myasthenia gravis, which includes neostigmine, pyridostigmine, edrophonium, drugs used in Alzheimer's disease, which includes rivastigmine, galantamine, donepezil. Now let's see mechanism of action of anticholinesterases. This diagram shows cholinergic neurotransmission. Here, whenever acetylcholine binds to the receptors, it is rapidly hydrolyzed with the help of enzyme called as acetylcholinesterase. This acetylcholinesterase catalyzes this enzyme reaction to convert acetylcholine to choline and acetic acid. Anticholinesterases reversibly or irreversibly binds to acetylcholinesterase enzyme and thereby inhibits the metabolism of acetylcholine. Due to inhibition of metabolism of acetylcholine, more acetylcholine will be available in the vicinity of this synaptic cleft, that is in cholinergic nerve terminals, and hence the action of acetylcholine is increased. So hence the effects of anticholinesterases is similar to any cholinergic drugs like pilocarpine. Irreversible inhibition is mainly seen with non-competitive inhibitors like organophosphorus poison, that is OP, and reversible inhibition is seen by other drugs like physostigmine, neostigmine, donepezil, rivastigmine. The major difference between acetylcholine and anticholinesterases is the type of bond they form with acetylcholinesterase enzyme. Acetylcholine normally binds to anionic site, whereas edrophonium and tacrine, they also bind to anionic site but in the vicinity of tryptophan 86 and glutamate 202. Physostigmine and neostigmine, they also form more stable bond with acetylcholinesterase by forming methyl carbamoyl and dimethyl carbamoyl acetylcholinesterases. And that's why they are hydrolyzed by acetylcholinesterase more slower as compared to acetylcholine. Now, worse is seen with organophosphorus compounds, because organophosphorus compounds, they bind covalently to the esteric site, wherein the bond is much stronger as compared to competitive blockers. I would like to repeat here again, acetylcholine normally binds to anionic site, and similarly other competitive blockers too binds to anionic site, whereas non-competitive blockers like organophosphorus compounds, they bind covalently to esteric site of acetylcholinesterases. And not only that, they causes phosphorylation of these enzymes by addition of ethyl or methyl groups. And later, secondary or tertiary alkoxyl groups further stabilize this bond. And remember, once the time goes on, that is, we call it as aging, where there is loss of one of the alkoxyl group, then it is impossible to break this bond. Even if you use any drugs like oximes or any process, won't separate these bonds. Hence, aging is loss of one of the alkoxyl groups, which further stabilizes and forms a permanent bond. Once aging sets in, it is impossible to reactivate the enzyme by any drug or any process. Now let's discuss the effects or pharmacological actions of anticholinesterases. Now actions of anticholinesterases is same as cholinergic drugs like pilocarpine. So they cause constriction of pupil, increased salivary secretion, lacrimal secretion, causes constriction of bronchi, decreases the heart rate, it stimulates the acid secretion, causes contraction of the gallbladder, contraction of the detrusor muscle and relaxation of the bladder sphincter, as well as contraction of the anal wall and relaxation of the anal sphincter. The first group of drugs which I am going to discuss is competitive blockers. In that, prototype is physostigmine. Physostigmine basically is a tertiary amine compound, and all the tertiary amines can successfully cross blood-brain barrier, and that's why they can have effects in the central nervous system. Now, the first and foremost use of physostigmine is for the treatment of glaucoma. Now, mechanism of action is similar to pilocarpine. They cause miosis and they also increase iridocorneal angle, thereby increasing the ovuoscleral outflow of aqueous humor. And that's why they can be helpful for glaucoma like closed angle glaucoma or open angle glaucoma. For the treatment of glaucoma, physostigmine comes as ophthalmic solution. The second use of physostigmine is in anticholinergic drugs poisoning, like for example atropine poisoning or any other atropine like drug poisoning, poisoning with tricyclic antidepressants, poisoning with chlorpromazine or first generation antihistaminics. The preferred route of administration in this condition is slow IV. Another condition where this drug can be used is in prophylaxis of cholinesterase inhibitor poisoning. For example, nerve agent poisoning like Soman, Sarin, Tabun. It is commonly termed as Persian Gulf War syndrome. So in this condition, if the patients are pre-treated with any of these anticholinesterase like physostigmine or pyridostigmine, these drugs can prevent the effects of cholinesterase inhibitor poisoning. So it is used only for the prevention of the poisoning, but once the poisoning sets in, these drugs cannot help. Now let me summarize the uses of physostigmine. One is glaucoma, second is anticholinergic poisoning, and third is prophylaxis in cholinesterase inhibitor poisoning. Now let's move on to the next drug, edrophonium. Now, edrophonium, unlike physostigmine, it is a quaternary amine compound, means it won't cross blood-brain barrier. The significance or unique property of edrophonium is it is ultra short acting drug. And this short acting is mainly because of rapid renal elimination, unlike neostigmine, which is much longer acting than this. And because of its short acting nature, it has no therapeutic use. But it has another very important use is the diagnostic use. Edrophonium is used for the diagnosis of myasthenia gravis. It is typically given in the dose of 2 mg intravenously. If there is no effect, then it is followed by 8 mg intravenously. Upon administration of edrophonium in myasthenia gravis patient should show improvement in the strength. And also it must be unaccompanied by lingual fasciculations. Lingual fasciculations are common if the patient is not having myasthenia gravis. Another very important use of edrophonium is to distinguish between cholinergic crisis and myasthenia crisis in myasthenia gravis patient. If the edrophonium used in the myasthenia gravis patient causes further weakness, then that condition is cholinergic crisis, where you need to reduce the dose of anticholinesterase. If you find improvement in the patient with the administration of edrophonium, then that is myasthenia crisis, wherein you need to increase the dose of anticholinesterases. Neostigmine is one of the most important drug in this class. Neostigmine by nature, it's a quaternary amine compound, means it do not cross the blood-brain barrier, unlike physostigmine, which is a tertiary amine. The major use of neostigmine is for treatment of myasthenia gravis. Now, myasthenia gravis is a condition which is autoimmune, wherein it causes continued weakness in the muscles. Neostigmine in this condition causes symptomatic improvement. Hence, remember, these drugs cannot cure myasthenia gravis, but they can just cause symptomatic improvement. Now, other drugs which can be used in place of neostigmine is pyridostigmine, ambenonium. Another use of neostigmine is for post-operative paralytic ileus, wherein neostigmine relieves abdominal distension and as well as acute colonic pseudo-obstruction. The next use is for decuriorization. Now, decuriorization is very important use of neostigmine, wherein neostigmine reverses the skeletal muscle relaxation which is seen with skeletal muscle relaxants, especially curare-like drugs like D-tubocurarine, mivacurium, rapacurium, and so on. Especially drugs like D-tubocurarine and atracurium, they can cause prolonged muscle relaxation after the surgery. So in that condition, neostigmine can be given to reverse this muscle relaxation and to regain the muscle strength. The last condition where neostigmine can be used is in the atony of the urinary bladder, which is again used for post-operative dysuria. Hence, post-operative use of neostigmine mainly takes care of the decuriorization and as well as atony of the urinary bladder. The two important side effects that noted with neostigmine are bradycardia and GI spasms. Anticholinesterases also can be used in Alzheimer's disease. Now, Alzheimer's disease is mainly associated with deficiency of intact cholinergic neurons, which leads to dysfunction in cognition, memory, and as well as global clinical function. Now, anticholinesterases which are used in Alzheimer's disease are tacrine, but currently tacrine is withdrawn from the market because of hepatotoxicity. Now, the drugs which are commonly used in Alzheimer's disease are donepezil, rivastigmine, galantamine, and all of these drugs have mainly central action and they cross blood-brain barrier easily. Now let's move on to irreversible inhibitors or non-competitive blockers of anticholinesterases, which includes organophosphorus compounds like diflos, icothiopate, parathion, malathion, diazinon, which are mainly used as agricultural pesticides, insecticides, and as well as there is tabun, sarin, and soman, which are mainly used as chemical warfare agents, which are nerve gas agents, as well as tear gases. Icothiopate is the only organophosphorus compound which is used clinically, and it's used for the treatment of glaucoma, similarly as physostigmine. The only problem with icothiopate is it can induce cataract, and it is also can be absorbed systemically through ophthalmic solution and can cause systemic side effects. And as I mentioned already, diflos, parathion, malathion, and diazinon are mainly used as insecticides and pesticides, and they're commonly used by farmers. And the major problem with these compounds are They are also very well absorbed by the skin because they are highly lipid soluble. Whereas tabun, sarin and soman, they are mainly used as nerve gas agents or tear gas. And why they are used as nerve gas agents or tear gas? Because they are highly volatile agents and they are mainly used in chemical warfare and crowd control. What are the symptoms associated with organophosphorus compounds or toxicity? Now you need to remember this mnemonic called as my sludge. Here my means meiosis, S for salivation, L for lacrimation, U for urination, D for defecation, G for gastrointestinal upset, that is diarrhea, and E for emesis, which is vomiting. The other associated symptoms are difficulty in breathing because it causes bronchoconstriction, and as well as it has CNS effects like ataxia, mental confusion, delirium, hallucinations, etc. Now the next most important question is, how do you manage organophosphorus poisoning? The overall management of organophosphorus poisoning includes, first step is prevention of further absorption. As I told you, organophosphorus compounds are highly lipid soluble and they can be easily absorbed from the skin. And hence, you need to prevent transdermal absorption. So that, in order to do that, you can dispose of the clothes and destroy it, and as well as wash the skin or the affected skin by water. The second step what you can take is to prevent the absorption from the stomach, that is by doing gastric lavage. Then the next important step is ABC, that is maintenance of airway, breathing and circulation. So the patient has to be given 100% oxygen, and if required, patient can be put on ventilator. And if there is convulsions, you may have to treat with diazepam, which is GABAergic drug. But the mainstay of the treatment for organophosphorus poisoning includes use of atropine. Now atropine is anticholinergic drugs, which has actions exactly opposite of cholinergic drugs. So atropine is very important to reverse all the symptoms caused by organophosphorus. And they are typically started with 2 mg every 2 to 3 minutes until you see complete atropine effect, called as atropinization. Now the atropinization symptom or signs can be bronchodilation and mydriasis of the pupil. Now in the end, hundreds of milligrams of atropine may be required over the course of several days. Now along with atropine, it will be effective if you include pralidoxime. Now pralidoxymes are nothing but they are cholinesterase reactivators. Now thing with pralidoxime or any oxymes is early treatment is very important. If the treatment is delayed, they will be of no use because aging sets in. And the common dose used is 1 to 2 grams. So hence remember, early treatment with oxymes is very important. Otherwise, it won't be helpful because of the aging. The commonly used oxymes are pralidoxime, also called as 2-PAM, HI6, and obidoxime. So this finishes anticholinesterases. Thank you very much and goodbye.